Greetings and welcome to the University of Baltimore's Rosenberg Dialogue, Fixing Unintended Pandemic Medicaid Policy Consequences, Lessons Learned and Insurance Coverage Implications for Recipients. We at the University of Baltimore have experienced some of what you have experienced. The pandemic required an immediate and complete shift from mainly face-to-face courses to all online, some synchronous, some asynchronous. And now with the end of the public health emergency, we are managing a new type of what we say is a new normalcy. Today's webinar addresses the challenge of fixing unintended pandemic Medicaid policy consequences that came with the end of the public health emergency. Millions of enrollees were required to reestablish Medicaid eligibility. Our focus today is on lessons learned and insurance coverage implications for recipients. We examine this issue and lessons learned from three related perspectives. First, a national context and state variations. Second, Maryland Medicaid experiences with this policy complication for continuous enrollment. And third, generating data and information for evidence-based decisions. The University of Baltimore is ideally situated to convene and to contribute to this discussion. Our students, our faculty, and staff have a deep commitment to health policy and engagement beyond the walls of the university. I hope you find our webinar interesting and its insights informative into what is still an ongoing national challenge following the pandemic. And now, Alan Lyles, our moderator, will introduce our next speaker, Mr. John Kalin.
Thank you, President Schmoke. What I would like to do is first introduce myself. I'm your moderator for this webinar, and we're going to have approximately 20 minutes for each speaker. I want to give acknowledgement that the Henry A. Rosenberg Foundation and the University of Baltimore Foundation are responsible for the support for this dialogue series, which has been going on now for almost 25 years. The aim of this series is to explore opportunities between the private sector to work in partnership with the public and nonprofit sector to create a vibrant and economically strong society. Some organizational details for those in our audience. Our conference is being recorded, and afterwards a link to the recording will be sent to everyone who's registered. Our times are approximate today, and they may be affected by technology. If you have questions, please use the Q&A feature at the bottom of your screen. This is a webinar, so it's a bit different than a standard Zoom, but I think by now in the pandemic and post, most people have been accustomed to using webinars. We aim to have 1 to 2 live questions following comments from our speakers, and an open Q&A period at the end following Ms. Alice Middleton's comments. If your questions are not answered live, we will do so after the event and share that with our attendees. The keynote for our event today is Mr. John Kalin. Mr. Kalin is Senior Vice President and Head of Federal Affairs for Centene Corporation. He is also adjunct faculty at the University of Baltimore. John has an extensive, diverse domestic and international executive level experience in the healthcare industry. He spans government, academia, insurers, and has been leading Centene's Washington, D.C. based federal advocacy team for commercial health insurance, Medicaid, Medicare, and other lines of business. The issue that we're addressing in this webinar is exactly in the domain in which John works. His company covers multiple states with the Medicaid program, and it gives him an unusually acute sense of the variations that the end of the pandemic and the end of the policies mandating continuous enrollment in Medicaid have. In prior positions, Mr. Kalin has been Senior Vice President for Health Reform at United Health Group, the largest health insurer in the United States, and Executive Director of the Hilltop Institute, among others. if I went on, I think I would embarrass John, and I don't want to do that.
Yeah, please stop. Yeah, thank you.
There's a lot there. Dr. Moran currently serves as Deputy Secretary for Healthcare Financing and Medicaid Director for the Maryland Department of Health. In this role, he is a key member of the Maryland Department of Health's leadership team. He oversees the state's commitment to its Medicaid program, serving 1.7 million Marylanders receiving acute care, outpatient, and behavioral health services. That is a substantial proportion of our entire population. Previously, Dr. Moran served as Chief Executive Officer, Whitman Walker Health System, a community-centered enterprise committed to advancing social justice and equality through health. His leadership was integral in positioning Whitman Walker as the nation's leader in LGBTQ+ inclusive care, advocacy, research, policy, and education. He has other extensive material and important accomplishments, but again, I don't want to belabor that. I'd rather that we get on to hear what our speakers have to say. I would note that Dr. Moran's doctorate is in public health from the Johns Hopkins Bloomberg School of Public Health. He is a John Hume Scholar at Johns Hopkins, someone who has been identified for the potential and future significant contributions in public health. And our third speaker, Alice Middleton, is the Deputy Director of the Hilltop Institute at UMBC. She provides leadership on programmatic strategy, direction, and delivery of client engagements for research, policy analysis, and data analytics on Medicaid, healthcare finance, and delivery system reform. She oversees Hilltop's work with the Maryland Department of Health, Hilltop's long partner. Before that, Ms. Middleton was at the Centers for Medicaid and Medicare Services, where she was Deputy Director for its Division of Eligibility and Enrollment, which means that she has particular keen insights into the issue that we're discussing today. And prior to that, she held various director-level positions at the Maryland Department of Health, such as Deputy Director for the Office of Medicaid Planning and the Director of Eligibility Policy and Special Projects in the Office of Eligibility Services. I remember in a conversation that I had with Alice, possibly a few years back now, where she said, I'm passionate about enrollment and eligibility because that's where it all begins. And I could feel the passion. So I'm delighted that she is among our speakers today. And with that, I would like to turn it over now to Mr. John Kalin.
All righty. Good afternoon, everyone. I just want to get my presentation up there. Can folks see that?
Yes.
Okay, great. All righty. Let me first, I want to start out by first thanking Alan and the University of Baltimore for inviting me to participate today. And I really appreciate the opportunity to be on this panel, especially with Ryan, who I've just gotten to know a little bit, and Alice, who I've known and worked with quite a bit over the last several years. And indeed, I can echo Alan's comments. Every time I talk to Alice about eligibility, she is quite passionate, and it's always great to have those conversations, and I learn a lot from it. So I want to start with a bit of a personal note, though, in terms of my relationship with the University of Baltimore. So, and I'm reflecting on the fact that I've been affiliated with the University of Baltimore for about 25 years. Actually, I began teaching in the health systems management program back in 1999, and that's actually where I first met Alan. And I've had the opportunity and the pleasure of teaching in both undergraduate health systems management and the graduate level health systems management program. And Alan and I have collaborated on some courses and have stayed in touch over the last many years. And I must say, he's a superb teacher and a real scholar. And Alan, it's a pleasure to see you on the screen and be part of this. Really, really appreciate it. And I'm also going to reflect a little bit on the university and the important role that UBalt plays in our healthcare and our educational ecosystem. And for me, one of the most rewarding endeavors I've ever been involved in has actually been teaching in this program and helping, and in some cases, mentoring students achieve a career in this vast healthcare ecosystem that we're going to touch on and talk about today. And many of the students that we've worked with, Alan, myself, and many, many of the other faculty, have done this part-time. They've done it on weekends. They've done it over the course of years to get their degrees, both graduate and undergraduate degrees. And I want to just thank President Schmoke, thank you and the university really for what I think is filling this vital gap in our higher education system, which is to give people these kinds of opportunities. And I feel very strongly that as the debate in our healthcare system talks more and more about health equity and inclusiveness and themes like that, that our health policymakers need to reflect the diverse backgrounds of the individuals in the system. So thank you, Baltimore, for doing that. And I just so enjoy and am gratified at my affiliation with you all. So getting that reflection out of the way, I felt the need to say that because I feel very passionate about it. I'm also very passionate, maybe not as much as Alice, but very passionate about the topic today that we're going to talk about, which is the redeterminations. And the way I've had kind of a front row seat on this since the pandemic began, and I'm going to reflect on some of that. But it's also a case, I think, where we've had a very strong private and public partnership to achieve many of the goals that we all share, which is making sure that people get coverage, can stay covered, get in the right programs. And as the discussion evolves today, we'll hear about some of the very good things that came out of this in terms of lessons learned, which is we implemented a series of policies, we tested those, we tried to evaluate those, we were flexible and nimble to make some changes, and we're going to be very focused to the theme of this particular event about, how do we make sure that we've learned from this, and this is not a one and done process. So let me just do a couple quick backgrounds. Alan, thank you so much for the introduction. And I am going to make this just very brief about our company, but I want to, this kind of gives you a sense of that perspective Alan talked about. So Centene Corporation, which many of you may not have heard of, and unfortunately we don't operate in Maryland, but the company operates in 31 states. We're actually the largest health insurer in the Medicaid managed care space throughout the country. And this map kind of shows the states that we're in. And we're also active in the Medicare Advantage program, especially for the so-called dual eligibles, people that have Medicare and Medicaid. And the company has been very committed to the marketplace and the exchanges. And we've been in that since the beginning through its ups and downs. And we've had a very successful business in the exchanges. And actually that enrollment number is out of date now because we have over 4 million members as of January. And we're also a standalone prescription drug plan provider under the Medicare program. So if we look at those products that we're in, the theme is we're really public insurance. We're government focused and really working closely with our state partners in the case of Medicaid, with our federal partners in the case of Medicare and Medicaid. And the other thing about the company that I just want to point out, one of the reasons you may not have heard of Centene is that we actually don't use that name in the local markets that we're in. We like to think of ourselves as uniquely local. And as Ryan, as Medicaid director, can certainly attest to, each of the Medicaid programs in the country is different because the states actually administer Medicaid. So we're very focused on our states and the partnerships that we have with our states. to the point of, our plan in Florida is called Sunshine Health. Our plan in Georgia is called Peach State Health. So we're very, very locally focused. And I think that gives our company a lot of credibility and a lot of commitment to the local markets that we operate in. The other thing that I want to point out in terms of lessons learned, big picture, and then I'll get to some of the specifics on this topic, is the pandemic and the big economic downturn that occurred. Really, we're up at almost exactly 4 years ago when all this happened in the spring of 20. It was really the first giant test of what I call the durability of the safety net that we created under the Affordable Care Act. And remember, that had two critical components. One was the expansion of Medicaid, which many states took up, not all, for adults, and then also the creation of the marketplaces and the exchanges, where people with incomes below a certain level could get subsidies to buy coverage on the exchange. And we changed the rules so that people with pre-existing conditions could get coverage. And what we found is when this very quick, harsh recession hit in the spring of 20, and a lot of people lost their jobs, the Medicaid program was there as a safety net. The expansion of Medicaid, which had just occurred in 2014, marketplaces, didn't even exist before 2014. They were there. So the safety net of our country that we created actually worked. And that's an important lesson learned and something that we can really celebrate. The other thing I want to point out as preliminary to this conversation is, remember, as we think about Medicaid, it is a federal and state partnership, as it's called. The federal government actually pays a lot. They pay the majority of Medicaid, depending on the state's relative wealth. The states have a big share, obviously, but it's the states that really set a lot of the rules and set a lot of the payment levels and those kinds of things. So each state, the way they approach this particular topic was a little bit different in the context of broad federal guidelines. The other thing to keep in mind as we think about the big picture and lessons learned is, for those that study the Medicaid program and state finances, is we think of Medicaid as being like a counter-cyclical program. And by that, we mean that when the economy contracts and when we have job losses, obviously more people are going to move into the safety net and get coverage through a program like Medicaid. The catch-22, though, is at that exact moment that the economy might be contracting, the state's responsibility, they have to pay part of this, their revenues are also constrained. And so they get kind of a double whammy. And if we go back to the big recession, the so-called Great Recession of 2009, when the Obama administration came in and they passed the big rescue bill back then, they included increases in what the federal government would pay for Medicaid to states so as to cushion or help with that counter-cyclical. And I put that history in there because that lays the groundwork for the expectation of what we did in 2020 with the first big coronavirus bill. And then the last thing to keep in mind with Medicaid, that over the last 20 years, the Medicaid delivery system has largely been driven by private health plans. States typically contracting with companies like ours or other companies to actually deliver the Medicaid benefit through contracts and through very rigorous programmatic requirements. But you've got a private entity, and that's when I started about a public-private partnership being very key to that. So with that as background, let me move on to, I'm having a hard time advancing my slide here. There we go. I labeled this one, How We Got Here, Medicaid Grows from Continuous Enrollment. So I had mentioned the preceding big recovery bill in 2009 and the counter-cyclical nature of Medicaid. And if we go back exactly 4 years ago, it's really April, May of 2020, We were seeing the big job losses. We were anticipating fairly big growth in Medicaid. We were anticipating people who were becoming unemployed, maybe going into these safety net programs. So the Congress, in one of those early bills, passed legislation that had two really important components. One is from a countercyclical standpoint, they said we are going to provide an additional amount of federal dollars for states so that they can deal with this increase in enrollment that was expected. The second thing they did was they said, in order to qualify for that extra money, extra federal money, we're going to require states to maintain their enrollment and their eligibility standards. So the practical effect of that was that people wouldn't be leaving Medicaid as they traditionally do. And both Ryan and Alice can talk, I'm sure we'll talk much more about this phenomena called churn. But what we see in the Medicaid program, unlike other insurance programs, is we see a sort of a cycle of people becoming eligible for income reasons, family reasons, whatever the specific eligibility is, but then they fall off the program. And sometimes they fall off because their incomes went up. Sometimes they fall off because they got a job. Sometimes they fall off because family situations change. But sometimes they fall off because of the paperwork requirement. The qualification requirements can be cumbersome. We'll talk about that more as we get to lessons learned. So there's a lot of sort of friction in that enrollment process that, in effect, disqualifies people who might otherwise be eligible. So what this provision did is it said, we're going to kind of stop that friction. We're going to freeze that friction, and we're going to make sure that people stay covered. And that was really important because, remember, we were in a public health emergency, and that it was important that people actually have coverage so they could access healthcare services. So these are different even than some other economic downturns that we had. So if we kind of fast forward from the spring of 2020 through 2023, and I've got a couple of data points here, we see that Medicaid enrollment grew quite a bit during that period of time, about 23 million people over the roughly 3+ years that that requirement was in effect. And then the chart to the right just talks about who were the people, the slices of people that gained enrollment. So we can see the adults, that would be a lot of the Medicaid expansion, those folks, that would be both new and members who retain coverage, and then kids were also significant beneficiaries of this requirement. And what's really interesting about this, and this is an area where I think more academic research would be really helpful to inform future policy debates, is there's not good line of sight in terms of the impact of the labor markets on this. So how many people were really retaining coverage because of the eligibility requirements versus people coming off of, say, employment-based insurance, or maybe were on exchanges and fell through. But we did, when in the summer of 21, I had a group of graduate students from the Kellogg School, Business School, work with me for the summer. And we did some studies in Florida because we had a hypothesis there that with the big impacts of the lockdowns and the huge tourism industry that they have there, we would likely detect some relationship with unemployment and Medicaid growth. And indeed, when we looked at the Orlando County area, we did see that the Medicaid enrollment there, in addition to the eligibility issues I talked about, were influenced by the closures there, the brief closures that occurred there. And I think that's going to be an area that we'll want to study more. Okay, let me move on to a little bit more on how we got here. And for me, this was something I actually had a front row seat on, where I actually worked on this legislation back in December of 22. And let me just give you the sort of sort of policy, political, what I call mashup. And it's so fascinating at the time, at times very frustrating to work with the Congress on issues this big, but fascinating is the word I would use in this case. So one of the critical elements of the additional federal matching funds and the requirement that states not disqualify people was it was tied to the public health emergency. And the public health emergency was invoked way back when the pandemic started. And really, as long as that public health emergency stayed in effect, states could qualify for the additional funding, but they would also have to keep the eligibility standards as they were. So it was kind of that symmetry there. As we proceeded through 22 in particular, and the pandemic starting to recede, it was really fascinating for anybody in this world. So the Medicaid directors like Ryan, the researchers and policy community like Alice, the states for sure, the health plans, because they had a lot of these enrollees, everybody would wait and wait for the next extension of that public health emergency, because they knew that if it was extended, the enrollment would largely stay stable. And when it ended, there would be obviously this process going on. So the reason I call it kind of a mashup is that there were competing forces in the Congress around what to do, as everybody knew eventually this public health emergency would need to end and these redeterminations would need to start up again. So on the one hand, many of the progressive community were worried that if the public health emergency just ended, there was like a 90-day tail on it, but if it just ended without a lot of guidelines, remember, we have 20 plus or close to 20 million people that are now staying in Medicaid. What would happen? What would the guidelines be? Would it be the Wild West out there, for example? You had some on the more conservative leaning that were saying, wow, this Medicaid program is getting bigger and bigger, and we're spending more and more money on it. And surely there are people in there that are working. They have employment-based insurance, and they have access to other coverage. So why are we paying this money? So you had that factor. Then you had the states themselves, and Ryan can obviously speak more to this, but the states really wanting some certainty on how this was going to play out. And then off to the side on all this, and this only exists in Washington, D.C., in the world of Congress, with the unique budgeting that Congress does, is there was the CBO estimating that if the emergency, if we were to separate the eligibility requirements from the emergency, we could actually generate, quote, a pay for or a savings. These are terms that are used in this unique world of Washington. And so you had all these stars aligning, the conservative, the more progressive, the states, and the budgetary component of this thing. So what came together in December of 22, and I had the pleasure, I guess you could say, of working with a lot of the staff on this, because our company had a lot of the data, because remember, a lot of these individuals are in managed care plans. The Congress actually passed this law that structured and defined the beginning of the wind down, so that states would get sort of a declining share of this additional money in an orderly way. And then the law also set about guidelines for states that CMS ultimately strengthened, but guidelines around how this process should work. So we get certainty, that the states and others wanted. We get the opportunity to get back to some semblance of normality. And then we get a process that's never been done before, which is having to requalify and redetermine eligibility for literally the entire Medicaid program, which was a huge undertaking. So there was a lot of, requirements and standards that were implemented. And I said at the beginning how we kind of learned and tested, and this was kind of an ongoing process. And it's been underway, and we'll provide a few data points to show how show how that's going. And one of the things that I want to highlight and really call out is beginning really almost 2 years ago now, CMS was reaching out to states and to health plans to really begin thinking about, nobody knew when the process would begin, but to begin thinking about, well, what are all the steps in the process? And as I said earlier, because health plans enroll the majority of the Medicaid membership, the role of plans was very important. And we have a lot of contact information because we work, deal with our members, and that was very helpful in this partnership. A couple more data points, and then I want to be respectful of time. We'll move on to some of the lessons learned. We're more than halfway through this process, and remember what this process requires is pretty much all the Medicaid membership needs to be redetermined. And by that we mean, is their income low enough? Does it meet the standards? Does their family status meet the standards? A variety of other kinds of requirements. And what we've seen is, unfortunately, a lot of the disenrollments have been for what is called procedural reasons. And just think about this. This is, classic behavioral economics, kind of human nature. If we just send somebody an envelope and it's in paper and we ask them to open it and fill it out, two things can happen. One is they could have moved, which is often the case, and they never would have gotten it. And second, like all of us, we might get things and we just procrastinate. So just doing this on paper has been a problem. And I think I think both Alice and Ryan are going to talk about this notion of ex parte renewals. And that's where, if we can use automated data sets on people's income, we might be able to qualify them or requalify them with a lot less friction, and that's been something that's been a really big improvement in the eligibility process. In terms of the role of health plans, it's been really fascinating on this one too, because if we go back to the beginning of managed care and this managed care journey, and I actually was at Maryland when it was implementing Medicaid managed care back in 1999, when I was at Hilltop Institute, there was always a sort of an inherent distrust about the role of the private health plan in marketing or, unduly influencing members' choices. And some of that legacy, and maybe distrust isn't the right word, maybe it's just skepticism, some of that legacy kind of continued through this process. And we broke a lot of that down, actually, because, as I mentioned, a lot of the individuals are in managed care, and the managed care plans have a lot of relationships, a lot of touch points with these members. And so through working with CMS and a lot of our states, we were able to be a key partner in engaging with the member or engaging with the physician offices or the other groups to make sure that the member knew that they had to requalify. Maybe there's some states we could help them. Maybe there are some states that actually would allow us to help the person move from the Medicaid product. Let's say their income went up from $18,000 to $24,000. They wouldn't be eligible as an individual for Medicaid, but they would be eligible for a big tax credit on the exchanges. Help that person move. And I know Maryland did some of this in its program. And so there was a lot of sort of back and forth listening, building trust in terms of the role of health plans in this process. I just want to give you an example of the kinds of efforts that were undertaken throughout the country, not just by our plan, but companies did in partnership, oftentimes with community-based organizations, different events, different outreaches. One of the things we're most proud of at Centene, we were constantly looking at what worked, and where were we successful. And one of the really fascinating things, I remember talking to our clinical teams that take the calls from members who have an issue. They couldn't get access to a doctor. They were confused on a particular therapy. And what we did is on the screen of that nurse. So this person has nothing to do with eligibility. They're there to help the member. On the screen, they could see, oh, John, you need to be requalified in the next 90 days. Can we help you do that? So first, just highlighting that, and then using a touch point that was otherwise happening when the member is, attenuated and thinking about their coverage. And that was hugely successful. In another state, super exciting. I actually went and spent a day with our plan in New York City, and they're allowed there to actually go out in the communities with mobile vans, and they just open up storefronts on the street because the population is so dense, and help people with their eligibility. And what I found as I sat with them is somebody wasn't qualified for Medicaid any longer, but they could say, well, you can get in the marketplace and you can get this tax credit in the marketplace. So it was very energizing to see that. And then one of our states actually allowed the health plans who had more current contact information, especially cell phone information, to actually go into the state system and update that contact information. All these fantastic developments and lessons learned for the future. I think I am running low on time, Alan, so I'm going to just wrap up. These are some of the examples that I just talked about of things that we were doing in some of the states. And the hope is this will become institutionalized and will be very precise and data-driven about what worked, and we can be more fine-tuned. So let me close with just a couple of lessons learned that I didn't touch on. And thematically, I kind of emphasize this, is our enrollment process still has a lot of friction points in it. And if we think about all the consumer engagement we have across other lines of business, whether it's banking, whether it's our cable companies, as painful as that can be at times, and other things, is a lot of them have reduced the friction points, and we can learn from them as well. And I think both Ryan and Alice will talk about the automated ex parte data matching that will be really key in this going forward. And then I think Ryan, his slides will also talk about some of the waivers and flexibilities that CMS allowed during this unwinding. And we need to really understand which ones of those were really most effective. And maybe we can institutionalize those and make sure that they're included in the future processes. And then lastly, I think we learned a lot about the flexibilities if we can kind of motivate the ecosystem, including the health plans around outreach. That is really important. And we can't emphasize enough this notion of we've got this safety net now that extends beyond Medicaid and moves to marketplace. And with the very generous tax credits that are afforded under the IRA, people at lower income levels can actually move to free coverage in some cases in the marketplace. And that's enormously helpful in this process. And then I think we can lay the groundwork here for some of these social determinant of health goals that states and plans and policymakers share. And then the last slide is just a map of our products, and it kind of reinforces the fact that if you can look at some of our big states where we're actually in the marketplace and Medicaid, and we can facilitate some of these transitions, because really CMS has said this, and many other policymakers have said, we really just want to make sure that people are in the coverage plan that's appropriate for their eligibility. And we want to make sure that people have the right coverage that, again, is for their availability. So anyways, let me wrap up there. Really appreciate it. And I'm going to look forward to, I think, what our next speaker has to say, Ryan.
Thanks so much, John. Dr. Lyles, do you want to say anything, or you want to have me share screen?
Well, what I wanted to mention is we have a question, but I think it spans all three. and it probably will get rolled into what you're going to say, Dr. Moran. And the question is, what steps have been taken to help those with the high number of unenrolled due to procedural issues? So as you go through, you probably were going to incorporate that, but if you could, that would be great.
Absolutely. That's certainly the crux of the presentation. Let me share screen here. Do you all see that on your side, full screen?
Yes.
Great. It's wonderful when the tech works. I too, like John, want to start with a couple of different remarks and expressions of gratitude. I certainly want to thank President Schmoke and the University of Baltimore for having such an important discussion. Really finds us at a key and critical moment for the country, as well as the Medicaid program here in Maryland, of which the University of Baltimore plays a critical role of in our state. Also want to thank Dr. Lyles and the Rosenberg Dialogue Series for the invitation to be here and provide and to participate and contribute to this important discussion. And then I also publicly, and I don't get to do this very often, but just extend incredible amount of gratitude to our strategic partners at the Hilltop Institute for the enormity of the work that you shoulder for us. Really, there is a unique relationship that exists with the Hilltop Institute and Maryland's Medicaid program. And I know that Alice will talk specifically about how that relationship evolves itself in the context of the public health emergency unwinding and redeterminations. But I just wanted to provide Alice and the entire team at Hilltop, including Cynthia Woodcock, the director, for a few more weeks, if you will, just the amount of gratitude that we hold to Hilltop in this endeavor. And then also, I find it odd that, you know, there's one spokesperson often for these types of things, but I could not begin this presentation to talk about any amount of this work without recognizing the 700 colleagues that work in the Maryland Medicaid Administration. We are a team of 700 at Maryland Medicaid, and the work of unwinding and redeterminations even prior before that to ensure that there was continuity of coverage during the public health emergency is a testament to their hard work and their dedication. And I've been in a few places, as you heard from my bio, in the course of my career, and I've never worked in an environment with such dedicated people who are serving on the front lines. And this was obviously one of the most historic elements of any of their careers, and certainly of mine, as when we think about this uniqueness, unprecedented nature. My goal for the conversation that we have over the next 20 minutes is to take really what John said, and John gave an excellent overview of sort of the national landscape, how this all came to be from federal guidance, post-pandemic, and to really talk to you about how does the state grapple with the directive of this task of re-enrolling members. And how do you do it in a way that demonstrates your value proposition in the process as well for some of the opportunities that were outlined. And so I'm looking forward to providing sort of a real life case example, if you will, as an academic person who loves to spend time in the classroom as myself. I'll call this a case study of practice for us to consider. And I'll talk to you very much about the series of events that leads us to where we are here in April of 2024. So I won't spend much time here because John did a great job of going over how we got here from the federal government's guidance. And I do want to note that because there was continuous enrollment, right, individuals who either had coverage at the start of the pandemic or obtained it throughout, there was no disenrollments happening in the Medicaid program. When we started this process, I even had some conversations with some of our managed care organizations when I was framing up this work, as we were through the National Association of Medicaid Directors, as unprecedented nature of redetermining every single member again. And some folks said, well, it's not unprecedented. We have done renewals all the time, right? Because even prior to COVID, individuals would go through this process on an annual basis. What made it unprecedented is thinking about how to chart that out over the course of a time period. how to ensure that you've got cohorts and balancing by months. And then also from a state's perspective, there were a number of system enhancements that were made to keep people covered. And then thinking about all those system deconstruction, if you will, about how to move back to, quote, regular operations in this. It was and has been truly an enormous task. I want to note specifically here in the state of Maryland that prior to the public health emergency and continuous eligibility being required for that period, we were about 1.4 million Medicaid recipients. We actually saw our peak enrollment grow to 1.8 million at the start of our unwinding process. It got that at the late April period before we began disenrollments in April of 2023. So that is a significant increase, right? 25 to about 30% of an increase over the course of that particular period. States, I think it's important to note that, you know, and I love how John framed it as a federal and state partnership that Medicaid is. Of course, the federal government and CMS is also a regulator, but it's definitely a state partnership in terms of being jointly finances, and then states having the latitude in terms of coming up with a number of different provisions to operate the Medicaid program. States were given the choice of how long their unwinding periods could be, and this has led to a lot of variability in terms of contextualizing the data that's coming out in terms of you know, comparing state by state basis as well as state by state strategy. One of those differences has been there were some of our colleagues in other Medicaid programs that elected shorter time periods than the 12-month, which is the longest period that you could elect. We here in the state of Maryland elected to go for a full 12 months. Other states, Arkansas, others went to a shorter time unwinding period of 6 months. So while some state programs and state Medicaid agencies are, if you will, completed with their process of their unwinding period, we in the state of Maryland are in our very last month of our unwinding process and elected for a full 12-month period. What also, I just also want to reiterate, and John talked about it in terms of health plan involvement, and that has certainly been true for our managed care organizations in the state of Maryland, which covers approximately 86% of all of our Medicaid participants in the state, is there has been really, and it is an understatement to say, really an enormous amount of outreach and communication and partnership with community-based organizations. My background is in community and population health. I also, you know, carry very, very deep roots in rural West Virginia as a preacher's kid, and I understand that you don't reach communities, you find communities where they are. And so thinking about outreach strategies, grassroots activities, trusted community relationships and partners that are forged by places where people work, worship, play, name the place. It was so important. One of the hallmarks of Maryland's approach was coming up with a very much tested through participants from a marketing perspective, included feedback from Medicaid members itself, but how do we actually roll this out to let people know that we're beginning this process again? And one of the things that was created was a comprehensive Medicaid check-in campaign. I'm not a marketing person by background, but you can see how majority of our enrollees go through the Maryland Health Connection for Medicaid, and you can see the colors, right, of Maryland Health Connection and Medicaid check-in campaign even being the same because participants recognized, right, Maryland Health Connection and what that was. So there's very number of different intentional strategies here, but really this has been an ongoing process for the last 14 months, if you will, and it's in partnership and jointly financed with our managed care organizations as well. But awareness of the redetermination process. I think another important point is language access, and the campaign is primarily run in English and Spanish. And I'll get into some of sort of the collateral and other things that's provided as part of the campaign. But we also have materials that's translated in a host of a number of different other languages that we provide to our partners as well. Again, this campaign of Medicaid check-in has been multimedia approach, including every type of digital and search that you can find. I often know that our campaign is working when friends of mine send screenshots of Nextdoor, the application, which I'm not on Nextdoor as a neighborhood gossiper, but I know that some of you might be. That's not to claim you as a Medicaid gossiper, as a neighborhood gossiper. Anyhow, regardless, I often know that our campaign is working when folks would send me screenshots of the Medicaid check-in campaign. I mean, that just, sort of validates that we were on all different types of channels as part of this process. And you can see that in addition to the primary languages being English and Spanish, a number of other languages were made to ensure that this campaign was accessible to the communities across the state. Huge. I hate this slide. And I hate this slide because it does not come even close to representing the amount of work that we have done on the ground in every of the 24 jurisdictions across the state of Maryland. Huge amount of effort, both with state partnership, schools, back to school events, working with local superintendents, working with every provider association that you can think of every shape and size, hospitals being very important to our efforts. And then back to what I said earlier, community-based organizations, church bulletins, providing information in church basements through our partners. It's just been a wide variety of lift. One of the questions that was just phrased was how can the states, or how has states been trying to reduce the amount of procedural terminations into the program. And procedural termination defined as, you're an individual who was sent information about your redetermination period, and for whatever reason, you did not turn your paperwork back in, right? That could be because of a number of different reasons, right? One of the most important things about the campaign was not just to say that Medicaid renewals are beginning again, but what we also wanted individuals to do, and what the campaign drove, was we wanted them to update their contact information in our system. So if you've been continuously eligible, you may not have been gone back into that system for a few years. Well, that means you may have moved, you may have a different life scenario that we may not have the appropriate different information. So driving individuals to update that was really key to our work, and incorporating that as part of the message. But probably the most important thing to have reduced, if you will, the extent you can, procedural terminations was through the use of waivers and flexibilities that John sort of teed up as part of this, that states had the opportunity to do. So what CMS, did as part of this discussion was to say, we recognize states that this is going to be a huge lift. And we want to provide some supports that normally wouldn't be, if you will, allowable during pre-COVID or a regular course of an enrollment cycle. And we'll give you some waivers and flexibilities that will support that. And so in a very wonky way, these were referred to as E14A waivers, right, to support this particular process. And then you had some ability based on the work of CMS to have additional state strategies that would support with unwinding. Maryland was, and particularly at the start of the Moore-Miller administration, we became very aggressive in ensuring that we did everything we could to try to ensure that for people who are still eligible for Medicaid, that they retain their coverage. And that was a value proposition for us. And so we ranked among some of the top states, right, that allowed us to take advantage of some of these flexibilities to support our unwinding process. Some of those, and I'll talk a little bit more about this, but some of that includes the linking of SNAP eligibility with Medicaid eligibility, an important program, right, through the Department of Human Services, providing food assistance to families, but linking, which are very similar, if not the same, if you will, income requirements to Medicaid eligibility to automatically enroll participants. Another thing was another flexibility that's been huge has been looking at participants 100% of the federal poverty level or below, or at $0 who didn't have income within our data systems for a period of time. And then John also talked about allowing the managed care organizations that facilitate, if you will, our Medicaid programs, and we have 9 in the state of Maryland, to support our enrollment and renewal assistance. And John talked about some of the reservations that have been in place previously, or some of those factors why those had not been in place historically. We train more than 450 staff from managed care organizations to support the enrollees as part of this process. What I want to emphasize from this has just been a huge way to ensure that individuals retain coverage. We also, Maryland, are pretty fortunate to have a pretty robust technology infrastructure from a health information exchange platform perspective and our work with CRISP. And so we had a number of individuals, Alyssa Brown on our team specifically, who wakes up at 2 a.m. thinking about these issues, about how we protect Medicaid members, and said, you know, what if we leveraged CRISP, our health information exchange system, in partnership with providers, and sent providers a list of patients who were on their schedules for the next 3 months to say, hey, these folks are up for renewal. It would be beneficial for you to provide them with either on-site support, right, if that was a possibility, or remind them of how they can update their contact information and enroll in the process. The numbers here are outstanding. We have more than 48 provider organizations across the state of Maryland participating in this. And, you know, nearly in that 3-month spreadsheet file that we send to providers, right, 200,000 Medicaid members on every month are up on that 3-month file. And if you think about the 200,000 for, you know, the next 3 months in the context of the 1.8 million Marylanders of which we started, huge amount of connection to the providers to support this process as well. Another key opportunity to try to reduce procedural terminations and to ensure that paperwork is submitted back, if you will, is constant communication on the front end with multimedia approach. So not just in terms of paper forms or mailings, but leveraging automatic texting and phone robocalls as part of this. It's estimated from our estimates, and it could be more, it's likely not less, that a member in Maryland that's up for redebt in a 60-day window prior to their date of when their enrollment date is, that they get up to more than 7 touch points in that 60-day period of reminders of what happens. And then on the back end, we recognize that this period does allow individuals, right, from a first time of doing it, the necessary need for a safeguard. So we have what we call a 120-day reconsideration period, where individuals, if they miss their redetermination date in submitting their information, can come back into the system and if they're eligible, get coverage to the date that they were disenrolled. All services in that period would be covered in that 120-day period, and they wouldn't have to start a new application, if you will, all over again. So that's also been an important safeguard as well. Another opportunity to try to reduce procedural terminations, and you'll hear this this word a lot in Medicaid wonky policy realms, but ex parte, and ex parte is automatic enrollment. The state has a number of different data sources that we search from a variety of different places, where individuals, we can actually, particularly individuals who are for Medicaid on the basis of income, we can look at that information that's within the state data files for us that we have and actually determine their eligibility without even having to send them any kind of paperwork. So that's what we call an automatic renewal. And this is a really important process. Kudos to Alice and everyone in the state of Maryland since the Affordable Care Act and the inception of Maryland Health Connection, who have been working years of investments to try to improve our automatic enrollment rate. Prior to COVID, you probably see Maryland about a 45% of all individuals who had an automatic renewal, or we had an automatic renewal rate of that. But we also found in the process that some of the automatic enrollment processes from other states, Maryland included, were not being done correctly. We know that there are different eligibility requirements when you look at the household for children, if you will. So there are higher eligibility requirements for kids. And states, including Maryland, we were conducting renewals using household level data for individual children and not taking into consideration those higher eligibility income requirements. We and 29 other states were doing this practice. And one of the most important things to recognize as part of this, and I think Maryland led even in some of the national outlets on this, was when you have an opportunity to fix something and you're out of compliance, is accepting it, owning it, and fixing it. And that's what we did in terms of our mitigation plan and being very transparent about where we were in the process. Obviously, back to coming to a value perspective, wanting to do everything that we could to protect every Medicaid participant, but certainly knowing how important coverage is also for children. We certainly wanted to ensure that we were doing that correctly. And so just a huge amount of gratitude to our information technology teams for working to fix this in what I would call a record amount of speed, Maryland Health Benefit Connection, and our teams and the Department of Human Services for our other eligibility system that we use as well. We did. So what do we see when we went back and changed the system to ensure that we were conducting eligibility reviews correctly? We saw an increase of our automatic enrollment rate. That is significant. And why is that significant? It's significant because every increase, every person, right, who you're able to automatically enroll is paperwork that doesn't go to their facility, right, doesn't go to their house or whatever their address is. And so that takes away the ability or the risk of having a procedural termination. So automatic enrollment is a huge strategy to keep people covered. And you can see that, in November, we boasted a rate of up to 59%. Data that I just looked at for the month of March was at 2/3, which is huge. I mean, that leads the country top 10, top 5, probably, in terms of automatic enrollment rates when you look at us in Maryland compared to other states. The reality, too, is that we've been looking at all the data. We've been publicly transparent about all of the information from the top of the unwinding period, right? So states, there were reporting requirements as part of the federal Consolidated Appropriation Acts that states should report how they're doing in their unwinding periods and what those outcomes are of those renewals to the federal government. What wasn't necessarily required by the individual state was public presentation of that data. Maryland said we're absolutely going to be publishing all the work that we have. I'm very proud of the work of retaining coverage for almost 70% of everyone who's gone through this process. You can see through February, and we got a couple of months left. We've done almost 1.4 million of the 1.8, right, who are on deck. So, and then another important safeguard is we've been partnering very closely with the Maryland Health Connection to what John had said, which was easy enrollment pathways for individuals that may, because of their income, be ineligible for Medicaid, but could be eligible for zero or significant subsidies that would provide them coverage for qualified health plans through some of the health plans in the state of Maryland through the Maryland Health Connection. And so we worked on easy enrollment pathways for that work too. This is just a sample. You can go on our Medicaid check-in data website and you can find a lot more data. We've also been reporting data, super important in terms of this, thinking about health equity and driving our Medicaid check-in campaign strategy. But very big priority for the administration is to report data and information by race and ethnicity. We also have been cutting that data and looking at where do we need to do a better job on meeting communities where they are by age, by race, by region, by jurisdiction. And so you can see here that we've been looking at this and updating this in terms of our baseline enrollment. That has led, and then Hilltop has been extraordinary, right? They are the data engine behind us at Maryland Medicaid of creating, the appropriate surveillance in terms of mapping that's needed for us to look at. So you can see that these are maps that we have cut in 20 or more, probably, Alice, different ways that your team has produced for us to help guide our efforts. The last thing I'll end with is there's been a lot of discussion and conversation about how states stack up with one another and, who's doing better or who's doing this or who's doing that. And I've tried at the beginning of this process to really caveat people making stark conclusions on comparison of states because everyone had a different, as I talked about earlier, a different time frame potentially. So when you're looking at the data, it's not contextualizing it. Everyone had a different approach in terms of the waivers and flexibilities. Everybody's on different, shall I say, maturity of your information technology system. So some states have put in the investments, like I would say Maryland has for years in terms of automatic enrollment rates. So it just, I caution you. Another thing that makes this even more complicated in terms of looking at data currently is that there is a lot of states have taken longer to fix their auto renewal processes in terms of eligibility for children that I talked about than the state of Maryland did. And so with that, CMS is requiring states to pause any procedural terminations until those data systems are reflected. With that as the caveat, I'll say that we in Maryland are very proud of our work in being in the top 10. Sometimes we've been as top as the fourth best state in the nation in terms of people who were renewed and retained in coverage. Also in procedural disenrollment rates, we've also ranked high in that category. And again, that fluctuates based on states now needing to report their data from fixing their automatic enrollment rates. And so probably the most trusted source in this has been the Kaiser Family Foundation and their report that they have been reporting, because what they are doing is taking the national data as well as states that are reporting data publicly on their websites like we are and collating that all into two graphics. So with that, I'm happy, Dr. Lyles, to pass the reins to Alice, who I think will do really good justice for us of talking about how Hilltop was such an instrumental partner in terms of the research and the data analysis that the Medicaid program in Maryland absolutely needed to ensure that we've had a success as much as we've had. Let me try to stop sharing. There we go.
Great. Thank you so much, Ryan. So I think, as Dr. Lyles said, I am Alice Middleton. I'm the Deputy Director at the Hilltop Institute. And I'm super excited, as everyone said, I love eligibility. I'm super excited to talk about this topic today. I always like to say eligibility is the keys to the kingdom. Without eligibility, none of the rest of it matters. So it's always the starting point and super important. So thanks to Alan for inviting me to do this today. And thanks so much to the University of Baltimore for hosting this. I've known Alan for, I guess, over 10 years now, and I've been doing a Medicaid 101 every semester for his excellent students. I'm always impressed with their excellent questions and their thoughtful engagement. So thanks for all the work you do, Dr. Lyles. And thanks to John and Ryan for great presentations and kind of setting the stage for all of this important work that's happened over the last year or so in Medicaid. And thanks to Ryan for talking about our strong partnership with Maryland Medicaid. So I'm going to quickly kind of go through and describe how that relationship Ryan talked about works, give a little bit of background on Hilltop, and then talk about our role in this huge endeavor and how Hilltop kind of fits into the puzzle of redeterminations. So I'm going to try to share my screen. It worked earlier, so hopefully it'll work. Okay, and I'm going to start from the beginning. And hopefully everybody can see that now. Does that work, Dr. Lyles? Okay, great. So I really want to talk today about, how we supported the department with data to make evidence-based decisions and to have this really successful outcome that they've had with the unwinding. So a little bit about Hilltop. We are a research center on the campus of UMBC. We have about 50 staff with very wide-ranging expertise. The people are really the key to our success. We've got such a dedicated staff, experienced staff who really know Medicaid and know Maryland Medicaid specifically. And I'm really proud to work with all the pictures you see here. We're also guided by an external advisory board that helps us set priorities. And John Kalin actually helps us with some of that. As our former executive director, he always has really good insight. So we've got a really good setup at UMBC. So we were created about 30 years ago with the president of UMBC at the time and the then Secretary of Health, Nelson Sabatini. And our relationship has grown over the years. We started by supporting a really small program for Medicaid. And this grew as we took on rate setting in the late 90s, which John Kalin kind of spearheaded for Hilltop. And then as we took on that rate setting, we needed data to support. And so we started gathering all of the Medicaid data. And we are a nonpartisan institute and provide data to support Maryland's decision-making. So we support research, policy analysis, predictive modeling. We still continue to do that rate setting piece for Health Choice and for other Medicaid programs. We also do program development and evaluation. We have a decision support system, which we call Dataport, which I'll talk a little bit about because we built some modules out for this redetermination process as part of that, that the department can log into and sort of self-serve and see their data in quick time. And we also support LTSS Maryland, which is a sort of decision support for the long-term care group. And then, as I mentioned, we've got extensive data warehouses. We have Medicaid, Medicare, hospital discharge, assessment, commercial data. And we're able to match all of this at the individual level to support a really holistic view of how people are doing and how things are looking for Medicaid. So there are other Medicaid and university partnerships nationally. I would say Hilltop at UMBC and Maryland Medicaid are kind of the most mature of these. But we are part of a professional association for these kind of groups, and it's called SUPLIN, which is the State University Partnership Learning Network. And there's currently 33 active partnerships in 29 states that are similar to ours. So as a public university supporting the state Medicaid program. It's a really popular model for giving states local access to expertise and data analytics. And so we've really been supporting that SUPLIN group and do more and more collaborative work with those universities. So Hilltop has a great partnership, as Ryan mentioned, and as we've talked about. So we've got about a 40-page scope of work that we do annually for the department. But our partnership is really founded in flexibility and the ability to respond to priorities from the Department of Health. Our partnership builds on UMBC's mission of public service and the shared goals of improving the health and well-being of Marylanders, as well as a commitment to data-driven policymaking. So our agreement, we have an annual agreement, and it offers the state continuity and cost-effective data analytics. So in practice, what this looks like is really relationships, right? Ryan can call and say, I need this right away. And we support quick turnarounds if that's what's needed. It's constant collaboration and a real back and forth, which makes our partnership very strong. And then all of our staff are always paying attention to what are the department's priorities. And we're trying to make sure that the data we're producing for them is really answering the questions they need answered to make decisions. So our role in this whole unwinding process was like our role in many of the other projects we help the department with. Maryland has been really preparing for the unwinding since the very beginning. So as soon as the federal government announced we're not disenrolling anyone, I think the state said, well, then what? what are we going to do if we're not disenrolling anyone? What does that mean? How does that look going forward? And as Ryan mentioned, Alyssa has been a real thought leader in this space and has been thinking it through. And what does it mean for people? And so the reason the department has been so successful, as Ryan went through, is just really that approach. They have really basic project management principles. They've had a commitment from leadership to make this process really successful. And they've really made it clear that the focus has to be on coverage retention. They collaborated with their sister agencies, and they had a North Star and a consistent message throughout. And they also brought Hilltop in from the very beginning of the process. They knew that data was going to be key to being successful. So Hilltop assisted the department with enrollment estimates before we even got started. We said, this is what we think might happen. We've looked at some national estimates. This is what the Urban Institute is saying. This is what ASPE is saying. And if you look at these, here's some ranges. Here's some things you might want to think about as far as budgeting, as far as where to target some resources. And along with those national models, we were able to use what we knew, looking at previous trends, population growth, unemployment, and then looking at all those different kind of, we'll call churn scenarios, people in and out of Medicaid. And Hilltop also assisted the department with prioritizing and distributing renewals over the 12-month period. So as Ryan said, states were able to kind of design their plan. How are you going to do this unwinding? And you don't have to take the full time. Maryland chose to do so. And so we were really happy to help them think that through. Because Maryland was unique in never having stopped renewals during the period, Maryland continued to send out letters and say, please come back, please continue to renew. They never closed anyone, but they tried to keep the process going, keep people used to doing that process. And so we actually had a lot of data from that because we were able to see who would have closed but for this requirement that everyone had to stay open, who never responded. And so we were able to use that data to really help the department figure out who to prioritize. We were really careful to make sure that we helped think about spreading the workload across 12 months so that caseworkers weren't overwhelmed in any given month. We thought about making sure we were working around open enrollment because we know those months in November and December are always super busy for caseworkers because people are getting ready to sign up for their qualified health plans for the next year. And we really wanted to make sure we were reducing coverage losses so that people who were eligible stayed eligible. So that was a really good exercise, and it was good to really look at the data and figure out how to prioritize. So I think Ryan went through a little bit of this, but a little bit about Maryland, just to level set. We have a state-based marketplace. Some other states do not and use the healthcare.gov or the FFM, the federally facilitated marketplace. We don't have kind of that back and forth between going to the federal and then to the state once you're there's like an additional level of churn for those states that use the federally facilitated marketplace. We have a one-stop shop at marylandhealthconnection.gov, which makes things a little more streamlined for enrollees, which has been really good. And as Ryan mentioned, we have a very strong ex parte infrastructure or auto renewal infrastructure. It checks all available income systems in the state, and the state had been looking at about 50% auto renewed even prior to the PHE. So I think I talked a little bit about we never stopped doing the redeterminations during the PHE, and that was part of the data we used to kind of plan out the 12 months. And then Ryan really talked through, engaging partners at all levels. And I'll talk a little bit about how our data supported some of these outreach. We were able to provide some of the zip code level data to really figure out these media buys. we were able to send these files for the MCOs to figure out who was coming up for renewal. And we were involved in all of the conversations, kind of hear the policy as all of this was happening. So at Hilltop, we supported the Department of Health by keeping a data set we call the MRAD, or the Redeterminations Analytical Data Set. So monthly, we track everyone enrolled as of April 2023, and we look at information from our MMIS, or the claims payment system. And then we combine that with the data from Maryland Health Connection, the single streamlined eligibility enrollment system, as well as MD Think, which is the kind of the rest of the people are determined through that other eligibility system. And we get redet dates from those systems and combine all of that to have one big look to see who's up for renewal and what's happening. So we use this data to inform the outreach, but we also look at churn, and we're helping with projections for the state. And then we're also able to get qualified health plan enrollment data. So we can see who may not be eligible for Medicaid any longer, but is eligible for a qualified health plan. So, they lost Medicaid coverage, but they've moved into another coverage because they were over scale income. So that's been really helpful to the department. Oops, I think I skipped one. So Ryan showed part of this slide, this heat map here, which looks at the percent disenrolled, procedural, and not re-enrolled. And we've got a bunch of different measures, how many people have disenrolled altogether, how many were procedural versus non-procedural, who has a renewal coming up, who is extended, and then looking at re-enrolled versus not re-enrolled. And all of this is available at the county level, and then by all the demographics, right? So by age group, by race, ethnicity, and we are actually able to enhance the race ethnicity data that we were getting from the MMIS system by looking at other data sources. So really bringing in kind of that holistic view of the person to improve the quality of that data, to inform the outreach that Ryan talked about. So we built this in a Tableau-based tool, and this is behind a firewall, but the department can log in and see all of these details. And it's been really helpful, I think, county by county, as they talk to the legislature, as they talk to local health departments. This is where you are, this is the status. So it's informing, lots of different stakeholders as we move forward. So we also have it kind of at a more granular level, like the reason for closure. Did they fail to return the paperwork, or were they over scale income? And so that's been helpful to figure out who to prioritize. So as Ryan mentioned, we have really strong ex parte or auto renewal process in Maryland. Some states, just for comparison, are only at 10 or 12%. So when they run their population against all available data sources, they're only able to renew about 10% of them, and then 90% get a piece of paper in the mail and have to send it back. And so in Maryland, we are not having to send out all of those pieces of paper. We do send a piece of paper and say, you don't have to do anything. It looks like we've got all the information you need. If anything's changed, let us know. But you're good for another year. And we've successfully proved your coverage for the next year. So you can see here, this is for Magi only, but Maryland's ex parte renewal rate in March 2019 and March 2020, before the maintenance of effort and before COVID, were 54 and 57%. So you can see as I mentioned, we did prioritize those who were potentially no longer eligible in the early months, which I think contributed to kind of lowering our auto renewal rate. But we knew that was going to happen because those people had said or had come back, and we figured they were no longer eligible, but we kept them on anyway. But we still kept a pretty high ex parte rate, even in those early months. And then as additional flexibilities were implemented, the rate has gone as high as 65%. And I heard Ryan say it's still that high. I think we don't have the latest numbers on this chart, but continuing to really make strides and make sure that resources are focused on the people who really need them. And so these easy ones kind of get out of the way. Maryland does not have a backlog. So caseworkers are kind of working cases as they come, and people are getting their determinations very quickly, and are able to be processed in most cases same day, which is also not something a lot of other states can say. So as Ryan mentioned, one of the flexibilities or E14s that the state took up was to match against the Supplemental Nutritional Assistance Program, or SNAP. And these income limits are really similar to Medicaid. So if you're eligible for one, you're probably eligible for both. And so the federal government said, you don't have to ask people twice for the same information. Let's just use the eligibility to make sure that they can retain their coverage. So you can see this was really successful. We've renewed a lot of people using this method. And a lot of these, when we look behind this data, are a lot of children and a lot of parents, which are the groups that are primarily using SNAP. So really great to retain coverage for those groups. And this slide is showing those who disenroll each month, and then the percent that are coming back to coverage the following month. So it's a little busy, but this is sort of showing that concept of churn. So for the people who close, then how long does it take, and how many of them are coming back each month? So you can see in May 2023, we've got run out here through November 2023. Over 33% who closed in May have now reopened as of November. And so we are seeing a fair amount of churn. And I think, this information is so interesting, and I think can be actionable by the state. We can start to really drill down who's coming back versus who is not coming back. Are there ways to get at this group to auto renew them, right? Are there things they have in common? I think there's a lot that we can start to think through and really drill down on this data as we think about what's next, because as Ryan said, renewals never stop. We're going to keep doing this. And so I think the department is really serious about looking at data to figure out how to retain coverage for people. So finally, the other interesting data point that we haven't really been able to look at before, because we've never kind of paused to say, okay, who's renewing? Here's our cohort as of April 2023. We've been really able to more easily identify who's brand new to the program. And so we're on track to add about 150,000 brand new people to Medicaid over the 12 months of the unwinding. And when we're looking at this, about 90% of these new enrollees have never been known to Medicaid in the previous 5 years. And then for those enrolled and over age 21, just over 60% are female, and about a third of new enrollees are pregnant people, or what we call deemed newborns. So their parent gave birth while they were on Medicaid, and they get a year of Medicaid eligibility. So it's been interesting to take a look to see who are the new people. Oops. So what's next for us? I think we're going to continue to review all the data, make sure we can support the department in their budget projections, monitor this churn, figure out what we can learn, continue to create that actionable data for outreach, and help reduce those coverage losses. We want to continue projections to support their budget, to continue to support certainty for the program. And then the federal government has indicated that they're likely to continue to want states to report data. I think once you start asking for data, it's hard to say, oh, we don't need that anymore. So I think CMS is going to continue to push states, to be transparent and to continue to look at this to make sure it continues to be a priority for the state. So we're going to work very closely with the state to figure out what those requirements will be following the unwinding, and figure out what will be helpful and actionable for the state. So I think I'll conclude my comments there and stop sharing. And Alan, I'll turn it back to you.
Thank you, Alice. While I wait and I encourage the participants to post their questions on the Q&A at the bottom of the screen, a question for each of you. I've learned a lot today, and I read 4 newspapers every day. It's a luxury of being in academia. So how does someone who's interested in this issue that's dynamic, it's continuing, and so they have a good understanding at a cross-section at a point in time, but how do you stay abreast of this from the perspectives that each of you have brought? Because other than convening every month, I think that's not practical. And reading the newspapers, that doesn't seem to be, well, first of all, it's not very efficient. I can guarantee that. But it doesn't get at the kind of insights and information each of you have. So John, unless I'm on first call or a conference call for Wall Street, there are certain insights that wouldn't be shared too much in the newspaper. And Ryan, from the perspective of the state, I know that our students, for the most part, work. They have full-time jobs, and they intend their careers to be in the areas in which we all have had our careers. So how would they stay abreast of this? Is it to go to a certain website? Is there a KFF? Is that the answer? So I'll throw it open, whoever wants to take the first, but I would appreciate each of your insights.
Trying to find the button. I'm happy to take a stab at it, and I totally appreciate, and I think that's one of the biggest takeaways I've certainly had from public service and being a part of the administration is that there is a lot of attention from a media perspective, but understanding sort of some of the weeds of the issues, as well as sort of the decision and real-time discernment that state and other officials are making is certainly hard unless you're doing something type of a convenient where you can dive deep into some of these issues. I think a few things. One, I mentioned earlier that Kaiser Family Foundation, I think, has been doing some of the best in terms of data reporting. I also think, they're very data-driven, evidence-based, and nonpartisan in terms of looking at some of these issues and just trying to lead with sort of that data as well, which I think is very helpful from those sources. I also, I'll just take the moment and make a plug that from a state perspective, we do have a Medicaid advisory committee that every state Medicaid program is required to have. It is a monthly convening, and that is certainly an opportunity where any member of the public can attend. Alice mentioned that, data requirements and reporting will continue. I would also say that even before unwinding began, we were reporting, our enrollment numbers as part of our regular Medicaid advisory committees. We as a state Medicaid program know that there are going to be changes coming with additional federal guidance with some proposed rules of the composition as well as frequency, cadence of those Medicaid advisory committees. And so that's a space to watch as well. And then I would also be remiss too that just to mention, especially as we wrapped up the previous things, the 446th General Assembly legislative session here in the state of Maryland, that following the legislature as a key partner for the Maryland Department of Health and the Medicaid programs is really crucial as a informed citizen. Contextualizing the size and scope of Medicaid's budget, which is the case for all other states as well. Maryland passed a $63 billion budget. The Medicaid administration makes up about $15 billion of that when you wrap in both the state and federal funds. And then our other agencies, which are operators of Medicaid waiver programs, the Developmental Disabilities Administration being one. I mean, that's another $1.8 billion budget, if you will, and they take the partnership and guidance from Medicaid itself. So that's a long answer to say, following the legislative process and Medicaid's budget, which is often at the focus of budget conversations and legislative deliberation on expansion of care and services, is another way, particularly with students or people who are interested in policy development of this, to have an entryway into what's happening.
Thank you, Ryan. When I was in graduate school, the chairman of our department, Dr. Karen Davis, an economist, said, we should read things, but we should also look at the data, follow the numbers, because that tells you what the true commitments are. So I think that's a really insightful answer. John, what would you say for a publicly traded company who has such a large footprint in this area? How does one stay abreast of that?
Well, I'm going to first, as you were talking, I jotted down some ideas that more relate to academia. And I'll make a couple suggestions there, but I can talk about national companies too. It's interesting. Alice made a point at the beginning of her conversation about it kind of starts with eligibility, and enrollment. And I think as we look at the courses, just think about, the whole health domain. We get really focused on exciting topics like the U.S. government negotiating drug prices, and it's for 10 drugs, big deal. We get really excited over other things. Right now, the social determinants of health is a big area, rightly so. But really stressing, and you made a couple of these comments in your opening too, is if any of these public programs are going to work, we've got to pay attention to the operational and implementation issues, the blocking and tackling that are not a lot of fun in a lot of cases. But if we're going to get people enrolled, the only way these programs are going to succeed is if people are actually enrolled and able to use them. And I think that's a really big deal. So what I would say coming out of this is one of the things that Centene has been really, really focused on is we got a lot of momentum. We got a lot of awareness of what some of the challenges are, but these massive successes, both Alice and Ryan, with looking at the data, the churn data that she put up there, that should be every state should be looking at that, as well as CMS. And then I think Ryan made the point about some of the CMS reporting. I think we have seen CMS kind of step up in its role as well, because reporting this information and making people aware how important it is, I think, are really, key to this, and another one of these lessons learned. So I would like to stress the momentum, and really for policymakers, be they in the administration or be they on the Hill or be they in the classroom, understanding that if we're going to implement these different programs, we need to make sure that the entity doing the implementing can do it. And what are the friction points and how do we alleviate them?
Thank you so much. Alice?
So I would echo a lot of what Ryan suggested as far as looking for these items. I'll also say, CMS has a good listserv to kind of keep people updated. It's more at a national level, not totally focused on Maryland, but they have reports that KFF is kind of compiling, and they're sending those out. But they also have webinars and information about how to, get the information out to people, which are helpful. And then I'll also just say Ryan's check-in campaign website is still live, and that's a really good place. The state is posting all of their data there. They are reminding people. The toolkit is there for providers, and things are getting updated. I think the probably start to unwind the unwinding at some point. But that's all there. And then I'll just mention that at Hilltop, we actually have a public data port as well. So the data port I showed earlier was really on redeterminations and very granular for the department staff. But we also have information available publicly. And so every month we update that data and show where enrollment is going. So it can't tell you exactly how many people have been disenrolled, but it'll sort of show you the net impact of the disenrollments plus the new enrollments, and the kinds of people who are, where is coverage growing? Where are we losing coverage? And so that's been available on the Hilltop website for probably 15 or 20 years. And the department is committed to keeping that information open and accessible to the public.
Great. Once I've processed the recording, I'll add some of this information to the web page for the course, specifically the portal for Hilltop, et cetera. We have 3 questions, and one I would like to save for a wrap up at the end. It is more academic, but I'd like to think that it follows in the spirit of this. And so at the end, I would be asking each of you if there is a role for publication and partnering with applied scholarship with academics around archiving and making memorial the lessons learned through an event like this. I found the initial part of the pandemic, it was very instructive to look at the 1918 pandemic, to look at some of the other events. So I'll come back to that at the end. Before that, I'm not sure who the best person is. The question we have from a participant is, how is the information shared from CMS to the state and Hilltop?
Maybe I'll talk a little bit about I think the sharing of data. There's a lot of I'll just say information sharing that happens between the state and the federal relationship that exists with operating the program. Those things itself include when we're updating care and coverage of services in the Medicaid programs, different authorities that we seek or different notifications, I would call them in their most simplistic form, or requests for permission from states to move forward with those requirements, whether that's through a state plan work or whether that's through waiver authority or other mechanisms. So that is there's constant communication that the Medicaid program has with our CMS federal officials at that particular level. Let me just talk a little bit about unwinding. We have actually, from a state Medicaid agency perspective, been meeting on a weekly basis, Medicaid directors and other leaders that help facilitate this on a weekly basis with our federal partners. And that has been incredibly helpful for states to navigate, changing guidance, clarification of deliverables from federal programs to states. And it's really a testament to, I think, the Biden administration and the leadership at CMS for facilitating that ongoing dialogue as states move through this process. And I believe that Hilltop and team have also joined us on a number of those calls as they pertain to data as well, because that's also where we talk about some of the data information and the sharing. We are required as part of the Consolidated Appropriations Act, specifically about the data, to send that to the federal government, CMS, on a monthly basis. And so the process by which we use is we have data that Hilltop and others help us prepare for that submission to the federal government on a monthly basis. We then, once we submit and we do an internal review of that, we then post it publicly almost immediately to our webpage and website, which is how we share information then to the public as well. So I also, just with enormous amount of information and correspondence between the state programs and the feds as we've gone through this process.
Alice?
Yeah. So, I think all of that Ryan said, and we are also, for the calls that we don't join, his staff is always filling us in and letting us know this is what they're saying. There's state Medicaid director letters that are public. We read all of those, the informational bulletins, any kind of sub-regulatory guidance that CMS puts out. We're looking at all of that along with Ryan's staff at Medicaid. We also have been kind of joining a research convening led by the Urban Institute and some other funders. And that's been really helpful for information sharing kind of across states, and CMS joins and listens in. And so they're able to kind of weigh in and say, this is what's going on. This is what we're starting to think about. Nothing official, but that's been really helpful because this is such a big deal and sort of unprecedented. There's been a lot of talk and a lot of different convenings. And then finally, I'll say part of the SUPLIN, so the State University Partnership Learning Network that we're a part of, and it's through a professional association, Academy Health. The universities tend to do a lot of this evaluation work for state Medicaid programs. And so what we've done for years is sort of written up a lot of very technical methodological questions, sent them to our state partners. They forward them on to CMS. CMS sends them back. They don't really understand the question. And we play this terrible game of telephone. But more recently, CMS has said, why don't we start to really engage with the methods people? You're asking really like regression analysis and things that Ryan doesn't really have time to answer. So why don't we start a really like a methods group and really figure some of these data questions out? And so that's been really helpful. It's been, informal, but it's been helpful to have that cross-state collaboration and to have CMS kind of at the table, starting to think through some of these tougher questions.
Thank you. John, do you use the mechanism of data sharing, formal data sharing agreements?
Yeah. Well, a couple things. Important lesson learned for us, and I don't think I put this in the slides, but it was a topic that we talked a lot about in our internal discussions and as we engage with our states, which is getting the files from the states on enrollment and having an understanding of who was up for eligibility so we could do our outreach in addition to some of the other stakeholders. And then when they lost eligibility, reason for eligibility, loss, so we could better understand that, and also contact information. And I mentioned the Oregon experiment where that state recognizing that we the health plans might have more up-to-date contact info or more robust on cell phones, is being able to share that in a more automated fashion with the state. So that's one area. The second area I would say that is, I think, a big lesson learned, a big improvement is that I think that, as I said at the very outset of our talk, CMS really recognizing the vital role that health plans play in the Medicaid program in this particular area. We started engaging with them in really the end of 21, I think. And we had lots of back and forth with them individually and collectively around what we were seeing, what flexibilities we thought were important, what barriers we were observing, and sharing information. Like, we found that text messaging was very effective in terms of getting engagement, more so than say robocalls. And so sharing that. And I hope that coming out of that, we've been built, sort of a good rapport, a good trust relationship that plans who do enroll most of the Medicaid population should be a critical component of this ecosystem in terms of data, supplying the data, but also being recipients of information for like outreach and education and those kinds of things.
Great. Thank you. To move on to the next question, do you think the increase in pregnant women and newborns is due to the Healthy Family Coverage Group?
So Go ahead, Alice. Actually, go ahead, Alice.
I was going to say, yes, we are seeing a big increase. So this coverage group, so the Healthy Babies Act was implemented starting July 1st. So it sort of coincided with us starting to look at these numbers. And so, yes, we are seeing a lot of coverage for both new birthing parents as well as newborns through those coverage groups. I don't know if you wanted to add anything, Ryan.
Yeah, no, absolutely. I mean, the expansion of the Healthy Babies Equity Act and the implementation of that took place on July 1, 2023, certainly seen an increase of individuals who are predominantly through that particular coverage group. And so I would absolutely say yes. There's another question in the chat, which sort of like part and parcels to that, if I might, Dr. Lyles, which is to talk about Medicaid eligibility requirements,
Yes.
of which there are varying levels of Medicaid eligibility requirements depending on you as an individual, your potential medical status, your age, and so they, as well as at the household level for individuals or children, different eligibility requirements. So I think it might be best, we can certainly put it in the chat to talk about the eligibility requirements of what we provide on our website. And then to answer the question in terms of how can international individuals apply, there are certain requirements of immigration status for individuals to meet in order to be eligible for coverage. And there are also a number of different nuances as it relates to that in terms of immigration status and individuals who become qualified immigration statuses, and some exemptions that exist for having not to wait 5 years, right, to receive eligibility and coverage. And so there are a number of those, including pregnant individuals and children, but also some other groups. So that gets into very detailed guidance of which we can pose in the chat as well.
Thank you. Thank you very much.
Alice is the eligibility expert. Did I miss anything?
I think you skirted that excellently. It's very complicated, and I would say it's probably good for the chat.
Okay, thank you. And that comes from someone who has worked at the state and at the federal level on this. The next question, before I think we will be wrapping up and giving you time in your life back, and I'm grateful that you've spent this time with us, comes from one of our guests who asks, coming out of this process, how important will academic research be to identify which individual flexibilities and state policies are the most valuable to help coverage retention and support future Medicaid enrollment eligibility recommendations to policymakers? So a number of manuscripts will be written, and it will be spread across a wide literature. And I think a latent aspect of this question is how can the translating research into practice, how can that be optimized for the almost unique kind of experience that you're going through now? Where would that be published? How should that look? And if it's going to be academic research, it seems to me that there is an entire literature of peer-reviewed journals on implementation science that it might relate to. So again, I open that up to all of our panelists.
Well, maybe I'll start since we've been thinking a little bit about this at Hilltop. We are part of the Urban Institute Redetermination Unwinding Convening, and there are so many people starting to think about this. I think in addition to how did this unwinding period go, I think we're really interested in what happened during those 3 years. I've seen research that says people didn't even know they had coverage during that 3 years. They thought it was gone. But for the people who did we see better outcomes? Did we see, what was good about keeping this coverage for that long? Mm-hmm. So I think looking at that period is super interesting. And then also looking at what went well as far as implementation, what are the flexibilities that should and can be retained, given the statutory limitations that CMS has, and how can we continue to make strides with the collaborations we've made? How do we keep this at the forefront of everyone's hearts and minds? Because it's not just a one-time thing, and we need to have the stakeholders continue to be engaged, to continue to remind people to do this. So I'm really looking forward to partnering with some of our academic professionals to think about, how can we, what we call at Hilltop, really do this engaged scholarship, right? To write the papers that make the difference, and tell other states, this is what worked, this is what is actionable, and this is what we, would recommend you do if you want these kinds of outcomes. So Brian or John, I don't know if you have other comments.
I was thinking, Alice, what a wonderful set of research projects for Hilltop to lead or partnering, because the data and the measurement will be key. I also think we had this unusual opportunity. This is an experiment at scale. So going back to, I was talking about the counter-cyclical aspects of Medicaid. Yes, people stayed covered, but what role did coverage play, certainly in access to the pandemic needs, the healthcare needs of the pandemic? And I know that from the industry perspective, we've talked to our trade association, AHIP. Is there a way that they could work with some scholarly organizations to document some of these lessons learned? And I will say that kind of changing role of health plans in this, in terms of being a true partner with both the states and the U.S. government in this.
Yeah, I certainly would echo all that Alice said and John. And I think we feel pretty fortunate at the department that we have the relationship with the Hilltop that we do, so that we can think about some of these questions. We have certainly used, I think, the preliminary insights or analytics capabilities that they provided to help us think and answer some of these questions. I think the continuity and continuous eligibility question through the pandemic are very interesting questions to study, as Alice framed. We know that continuous eligibility for other contexts, particularly in the instances of children, is gaining national traction as well. So all states in the middle of this period of unwinding, also part of the Consolidated Appropriation Acts, was to require 12 months continuous eligibility for children, regardless of what happens in that 12-month period related to income in their particular household and how it would impact their eligibility. That you have to keep children at least covered and for a full 12-month period. And Maryland really led on that front and went live 4 months earlier than federal requirements were for that. But that's for all kids for a period of 12 months. You're also seeing some states begin continuous eligibility for kids up to a period of 6 years old. So these questions, I think, that Alice is bringing up about continuous eligibility, particularly for certain population groups, I think is a really interesting one as states begin to think about the mechanics of doing that through their managed care programs, as well as thinking about the logistics of and the implications, not necessarily logistics, but the implications of budgetary impact and otherwise of some of those decisions. But, having sort of a sense of what it does long term, I think is very helpful for policymakers and others to have those data points.
Excellent. If I could take a moderator's prerogative, I'd like to change my last question because it seemed too personal. It's just academics want to publish. Okay. But I think what's coming out of this at the end that's important is that we have engaged students, we have participants, and the recording of this will become an artifact that's available for other audiences. It'll be discoverable because it'll be on our website. It can be artifacts for education and courses that are relevant for what we teach and do. How does someone who is passionate and who is committed to the central issues that we're talking about here have effective voice to try and influence a policymaker? What does one do? As an academic, I think about trying to publish in the right place, not just high impact journal, but in the right place. But as a private citizen, I think about perhaps a commentary or an editorial, but is it right you're a representative? What do you suggest to those who are going to be practitioners, not academics, to have voice as well as to work professionally informed?
Maybe I'll start. I mean, I think, where we find ourselves at the moment and a critical inflection point for the country, I find all forms of democracy and participation to be highly encouraged in this day and climate, and whatever touch point that might be. I would say more specifically, after giving a full endorsement of any way that people stay active as part of the political and policy process, is that one of the things that I've gained so much more appreciation for is how influential that the state Medicaid program can be in terms of partnering with, yes, the members that we serve, but also provider communities and other organizations where Medicaid directly impacts them. It is true that it is the most important safeguard of coverage for about 25% of our state's population. It is also true that Medicaid is an economic driver and an engine that really funds a lot of jobs, a lot of security for provider organizations across the state as well. And I have found in the process that people often think of policymaker as an elected official in that regard of having to advocate for statutory change, and that is all true. That is certainly true, but the Medicaid agency, right, and the Maryland Department of Health and all of its agency also serves to stand as a key crafter of policy and direction and philosophical values, just as we've outlined as part of this discussion, as part of the way that we have led unwinding. And I highly encourage folks to think about the Medicaid agency if that's a particular area of focus. Obviously, it's one of the programs where it's advocated for, advocated against in a number of different scenarios based on political wielding, but to really think of the agency as a partner and think partnership with them first as part of your policy development and political process start.
Thank you, Ryan. John, then Alice.
Yep, that was very, very well stated, Brian. What I would say is a couple things in response. One is just at sort of a micro level, there's just so many different kinds of communication outlets that we're afforded today that we didn't really even have 10 years ago. And one of the things that we've noted coming out of the unwinding, I think all the speakers touched on, is all the different kinds of partnerships and different opportunities that we have to engage, whether it's small community-based organizations, whether it's larger entities, to provide them with insights, in some cases data. And I would also say it's certainly our experience in dealing with different groups on the Hill and in the administration is that personal stories about people's journeys really matter. And, we can talk about, and I've been involved in lots of discussions with Hill members and staff. You can talk about aggregate numbers and aggregate, process flows. But if you can, personalize somebody's journey and show how this one particular program, being eligible for it or being, caught up in this friction, made a difference, good or bad, that can also be very compelling. And so we shouldn't underestimate that as part of sort of the policymaking process.
Wonderful. Thank you very much for elevating that particular approach. A former Nobel laureate in economics has written a book called Narrative Economics, in which he is essentially making the same point. Alice?
These guys stole my answers, but I'll say, there's data available on our website, as I mentioned. I would encourage your students to kind of familiarize themselves with it, figure out, where they live, what the communities they're touching, what do things kind of look like. There's so many reports that the department does on very specific issues. And that's all available on their website. The legislature asked them to write so many different things and investigate so many different issues. There are fiscal notes for all of the bills that the state considers, even the ones that don't pass. And so looking at those, I think, are like an insight into how the sausage gets made a little bit. How much do these things cost? What are we really talking about? If you're interested in a policy issue. And I was going to say the same thing about the stories really mattering. And John, I remember a few times when I've come to your classes, your students are working in the field, right? And they have real horror stories about the things that have gone wrong and the things that need to be fixed. And so I would encourage them to think about not only their own lived experience, but what do they see when they're working with patients, when they're working at their call centers? What are the kinds of things they're hearing, and try to fix those problems and try to figure them out.
Thank you, Alice. I'd like to take this opportunity to thank each of you personally for sharing your time and your expertise, and for the recording, and for those participants who are still with us and those who will come later. I want to also point out that what you're hearing is these are the people who are not just technocratic. These are the values of lived lives. You see what motivates someone, and it's the passion, it's the mission, it's the commitment to making a difference. And it's not about personal legacy. It's about, in real time, making a difference in the lives of people. So I'm greatly appreciative you've spent this time with us. And on behalf of the University of Baltimore, thank you. And personally, I believe very much in reciprocity theory. So if there's ever anything that I can do for you, please let me know. It's open-ended.
Well, thank you, Alan. It's really terrific.
Thanks, John.
Thank you so much, everyone. Take care.
Thank you. Bye-bye.
Bye-bye. Jared, I think we can terminate the connection now.
Yep. Have a good one.
You too, sir. Thank you for all of your help.
You're welcome. Have a good one.
Bye.